has MARPE found its place? Welcome to the first episode of 2026, where I'll be looking at Miniscrew Assisted Expansion and what this clinical treatment modality has to offer. I'll discuss the two main designs of Miniscrew Assisted Expansion, as well as the actual effects of this taking place on the average patient. We'll discuss the differences in clinical protocols when it comes to its activation, as well as where Miniscrew Assisted Expansion can be a good adjunct for orthopaedic correction and enhance those effects. This podcast is a summary of an excellent webinar by AngleNet. This was delivered by Daniele Cantarella as well as Benedict Wilmes as part of the Angle Society's initiative to host monthly webinars. Just to recap, the podcast is the opinion piece of myself and the Orthodontics in Summary team. We try our best to ensure it's as accurate as possible, but may not 100% represent the original lecture. Starting off looking at the two main designs of Miniscrew Assisted Expansion. One is termed MSE, which stands for Maxillary Skeletal Expansion, and the second being MARPE, Miniscrew Assisted Rapid Palatal Expansion. Now, to just draw the key differences between these two designs. MSE consists of usually 4 miniscrews and was introduced by One Moon in 2012. The miniscrews are bicortical, going through the palatal cortical bone as well as the sinus cortical bone as well. Now, the miniscrews are positioned in the posterior aspect of the palate, and the rationale behind that for the MSE group is that's closest to the proximity of the resistance. The greatest resistance for maxillary expansion is the zygomatic buttress and the pterygopalatine suture, and in doing so, it means the expansion forces are perpendicular to the midpalatal suture and act around the center of resistance, which is bizygomatic line at the level of the first molar. That's in contrast to the MARPE group, which generally consists of 2 miniscrews, and these aren't positioned in the posterior aspect of the palate. It's in the mid-palate, in the so-called T-zone or the premolar region, and that was something presented by Benedict Wilmes back in 2016 and has been confirmed by Chang in 2021 as the area of greatest bone present in the palate, and that's between 6 to 9 millimeters. Now there's a question to be posed here, which is better, 2 or 4? Well, actually both groups will hold that the retention and anchorage supplied by the bone is the key factors. So for the MSE group, if there is a thin bone present posteriorly, less than 2 millimeters, additional miniscrews can be used, either laterally or anteriorly, to provide this anchorage, but maintaining the screw itself in that posterior aspect at the center of resistance. Now, the advantage in the MSE design itself is that the screw itself has housing to enable the positioning of those TADs, and they're fixed in their location. It means that there will always be a good appliance TAD fit. In terms of the MARPE group, they would propose that actually the best area of the bone is more in the mid-palatal region. So therefore prioritizing good anchorage would necessitate using the highest quality bone. And that puts us into that T-zone region. Now in terms of the appliance design, well, once the TADs are placed, then the appliance is constructed. Now this does leave some scope for a misfit between the TADs and the appliance itself. However, this group will prioritize having a bone first approach, ensuring that there is the best anchorage possible for the appliance itself. And with newer digital designs, reducing the chance of misfitting taking place. There was also a bone of contention here as to how those forces are delivered. In terms of the MARPE group, they would suggest you need the ideal bone in the mid-palatal region, which allows 500 grams plus of force to be distributed. That was beyond Ludwig's finite element modelling in that study from 2013. They would suggest that having TADs in a more posterior region gives poorer anchorage, and therefore the delivery of the force will be less accordingly. Overall, between these two designs, MSE and MARPE, there doesn't seem to be a clear winner between them, simply two different principles and philosophies at play. For the remaining podcasts, I'll include both of them in the same group, looking at the effects and other aspects of their design. The next question in terms of the design is, should it be purely bone-borne, or should there be some dental component? The advantage of having some dental component is that it can position the appliance, also stops the screw from rotating once the activation takes place. The downside is it can result in some dental expansion occurring during the expansion process. I love Daniele's Cantarella's opinion on this. He maintains the extension to the first molars during the expansion. As soon as it's completed, he then cuts them off, stopping any dental alveolar compensation or tipping then taking place. In terms of the expansion effects, both MSE and MARPE have shown to have parallel splits taking place of the mid-palatal suture. And that's something that we don't see taking place with conventional RME or even indeed with SARPE. An order of 4.5 millimeters of mid-palatal expansion takes place according to Daniele Cantarella's study from 2017, but with MARPE we get a similar amount at approximately 3.5 millimeters according to Garib's 2021 study. What about those two main resistors? What about the zygomatic buttress and the pterygopalatine suture? How do they behave with this expansion taking place? When it comes to zygomatic buttress, what we know is that there seems to be some bone bending which takes place in this region, according to Daniele's CBCT study. When it comes to looking at the pterygopalatine suture, approximately 53% of them have a split which occurs. So showing that the main resistors are either bent or broken during the process of Miniscrew Assisted Expansion. Is it symmetrical? Unfortunately not. On average, there's an asymmetrical change or expansion at approximately 1.1 millimeter difference from right to left. Now the reason for that are given as plenty. Unfortunately, it's not to do with the appliance design as what we understand. It more relates to the patient's anatomy as well as the geometry of the expansion taking place, resulting in some mild asymmetry in terms of expansion. What about orthopaedic change? We've described expansion occurring, but how about the use of class 3 cases? Well, this is where I think Miniscrew Assisted Expansion has a really significant role to play in managing our patients. This relates to the Turkish group's work, Ergol from 2025 from the AJODO, and they compared Miniscrew expansion to rapid maxillary expansion and the use of protraction face mask. And they found overall there was significantly and statistically more anterior-posterior correction in the Miniscrew assisted group, at approximately 1.6 millimeter greater advancement of the maxilla. There was also greater vertical control, with approximately 1.2 degrees less clockwise rotation of the mandible. And this fits in with Franchi's consensus statement from last year in Progress of Orthodontics, looking at Miniscrew usage. 25 experts across the world in this domain said that the use of skeletal expansion is advantageous to achieve better anterior-posterior correction. They also described the protocol for this, and they recommended the ALT-RAMEC protocol. So to recap, this is the alternate rapid maxillary expansion and constriction protocol. Now, Eric Liu proposed this back in 2014, and it essentially consists of a week of expansion of the mid-palatal screw, followed by constriction the following week, and alternating between the two. And the proposed effect of this is to loosen the circumaxillary sutures to allow greater anterior-posterior change, i.e. there is less resistance to the maxilla being able to move. In terms of engagement of the screw, monocortical versus bicortical. Well, in terms of expansion, it's been found monocortical screws have a greater deformation of approximately 5 degrees, whereas bicortical, i.e. extending long enough to go to the floor of the sinus, it's approximately 1.8 millimeters. Therefore, bicortical achieves greater stability of the miniscrew. It also gives greater expansion, as Troy's 2023 study showed, by approximately 1 millimeter. Activation protocols. In terms of expansion, rapid expansion has been proposed and follows through from conventional RME as well as MARPE, and that suffices in terms of 1 to 2 turns per day. However, slow expansion has also been proposed, and this is a really interesting concept. The idea of turning the screw to achieve approximately 0.5 millimeter to 1.5 millimeters per week. And the advantage of this slower expansion is it allows longer for bone bending to take place. It also results in a smaller diastema and less discomfort to patients. But interestingly, in Nikki Arveda and Hussein Agazeda's study from last year, comparing slow to rapid expansion with mini screws, they showed an equal amount of skeletal expansion. And that really starts to question what phenomenon is taking place here. It looks as though Miniscrew Assisted Expansion doesn't seem to be an adaptation of distraction osteogenesis. It more seems to relate to the phenomenon of bone bending, separation of midplatal suture, and potential changes and separation of the pterygomaxillary suture. Can we predict when Miniscrew Assisted Expansion will be successful for patients? Well, a classification of midplatal sutures was defined by Agarilli in his 2013 classic paper. However, the midplatal suture classification has shown not to be as accurate as we had hoped, with low correlation to actual separation. That was shown by Isfeld and Carlos Flores-Mer in 2019. So what do we have in terms of predicting the accuracy? I'm afraid it's more of an arbitrary age of our patients. What we do know is that up to the age of puberty, the use of miniscrews offers no advantage in terms of skeletal expansion. That was Farhan Bazagani's paper with Bjorn Ludwig, which evidenced no changes were different between those two groups. However, from puberty onwards, up to the age of 25 for males, where there's an 80% success rate, and up to 30 for females, where there's a 94% success rate of expansion, there seems to be a role for Miniscrew Assisted Expansion. Post this age, well, after that age, between the age of 30 onwards, success rates of midplatal separation with miniscrews is as low as 20%. That was Oliveira's paper from 2021. For these patients, we should consider more the use of SARPE or minimally invasive surgical miniscrew assisted expansion, or MSE MARPE as it's otherwise known, something that we'll cover in a future podcast. And although this podcast has been orientated around the treatment modality of MARPE, fundamentally the diagnosis of the transverse discrepancy still remains elusive, with different thoughts and processes. Do we use dental landmarks? Do we use skeletal landmarks? Does it necessitate a CBCT being taken? Well, even when CBCTs are used, there seems to be a large standard deviation according to the individual studies. That's Milner's paper and Lee's paper from 2022, which showed a standard deviation of up to 4.5 millimeters. This is a question that I'm hoping myself and my research team involving Carlos Flores-Mer, involving Samir Messian and Melody Shirazi will come to find the evidence later towards this year with a systematic review. That brings us to the end of this episode of Orthodontics in Summary. A quick update for me. I'm looking forward to collaborating with the European Aligner Society for their conference in April 2026. It's going to be exciting, and I'll share more details in the coming podcasts. But as always, please do subscribe and look forward to the next episode.